So yeah, thank you. Thanks for the invite to come and speak. So my name is Rebecca Lacey and I'm a social epidemiologist, and I have a particular kind of focus on life course epidemiology more specifically. And this is part of a SIPRU project that's looking at intimate partner violence, parents' mental health problems and the impacts that those things have on child and adolescent mental health problems. And today I'm going to be presenting something a little bit different, I think, to what other people are presenting. So I'm presenting work that's using cohort data, so it's not administrative data as such. So for this particular piece of work, we've used the Avon longitudinal study of parents and children, but this project as a whole will involve the use of some administrative data and also linking. We're going to be doing a little bit of work where we've got ALSPAC, this cohort that I'm going to be presenting on today, which is also linked to GP records as well. So sort of it's coming. So this is what we've got so far. Sorry, I keep going to the keyboard thinking I'm controlling the slides, but I'm not. So what do we mean by intimate partner violence, or IPV as I'm going to call it from this point forward? So IPV is any kind of behavior within an intimate relationship that causes physical, psychological or sexual harm. And unfortunately, it's something that's highly prevalent in most families. It's about 17 to 24% of women are estimated to have experienced at least one episode of IPV during their lifetime. It's consistently linked with mental health of victims, both as a consequence of experiencing IPV, but also as a potential risk factor for experiencing IPV. So we know that women who are depressed are much more likely to be victims of IPV, for instance. It's also been consistently linked with poorer mental health in children and adolescents that are involved in those situations. There hasn't been a huge amount of work that's been done to this point using longitudinal data, which is kind of where we kind of come in. And also there hasn't been a lot done looking at what might mitigate those associations between IPV experienced in childhood and our child and adolescent mental health. So that's kind of where we come in with this particular piece of work. So we want to look at what are the factors which potentially offset the potentially harmful influences of IPV. So yeah, so that's just what I've just said. So we're looking at assessing the extent to which positive experiences, well, I'll talk a bit more about what those might be, reduce the effect of IPV on symptoms of depression in adolescents. So we're specifically looking at adolescents in this particular piece of work. And just before I jump into all the methods and everything that we've done, I wanted to sort of have a bit of a discussion about what can cohort data provide for these types of research questions. Some of the things might seem quite obvious, but I think it's important to sort of point them out. So firstly, we have longitudinal data. I know there are lots of also longitudinal administrative data sets. So we're able to look at the temporal ordering of experiences, and that's something that we've done here. So we've looked at IPV experienced at a certain time point. We've got adolescent depression that happens after it. Using longitudinal data sets, we can also look at change, which is a really kind of, that's something great that we can do. These are kind of the obvious things I'm going to point out now, but I think this is really where the cohort data comes in. So we've got self-reported information on IPV. We've also got self-reported information on the adolescents' mental health. So the adolescents are rating themselves on a sort of validated scale that I'll talk about in a moment. And linked to this, we've got the same questions that are asked of everybody. So we're not relying on people presenting to services. Everybody in the data set is asked the same questions at around the same ages, and we have those often repeated over time. So that's really where the strength of these types of data sets come in. We also have really rich information on aspects of life that you just don't really pick up in administrative data sets, and many of those I'm going to be looking at today. So things like how much the child enjoys school, or the relationship between parents and how the child gets on with their parents, all of those kinds of things are things that it would be really incredibly difficult to pick up in administrative data sets, but we have those repeated over time in longitudinal data sets like ALSPAC. Okay, next slide. So ALSPAC, it's a population-based birth cohort, or more specifically, I think it's technically a prenatal cohort. So it recruited 14,500 pregnant mothers, so before the children were even born, with estimated due dates of between April 91 and December 1992. So those young people are now in their very early 30s. We were able to analyse almost 15,000 of those, so the ones that were still alive at 1 year. We've got repeated prospectively collected information on IPV at various time points, We've got lots of information on positive childhood experiences as well as adverse childhood experiences. And also we've got repeated measures of mental health. So it's a really good data set for these types of research questions. So going into the things that we've specifically looked at, so IPV, we have reports from the mother. We also have reports from the mother's partner as well, repeated over time. So we've got information on experiences of physical and emotional cruelty, which we had at 5 time points. We actually have more information than that, but we've decided to select this period. So we look at 5 time points from 2 years, 9 months through to 9 years, 2 months. In terms of adolescent depression, we've got the short moods and feelings questionnaire, the SMFQ, at age 18. Again, this is self-reported. So it's a validated scale. It's really widely used in these big population studies. And then we've taken account of a range of different covariates, most of which are captured early in the life course, so around birth or the very in infancy. So things like sex, ethnicity, and a range of different kind of family or maternal characteristics. In terms of the positive childhood experiences that we've looked at here, we've been informed by this thing called the HOPE framework, which is called the Health Outcomes from Positive Experiences. So this was a paper that came out in 2017, and the authors have put together a range of different potentially positive or buffering experiences that are likely to be helpful in mitigating the effects of adverse childhood experiences, and one of those being experiences of IPV. And these things range from things that happen within the family. So we have things like warm parenting, co-parenting alliance. There are also things to do with relationships with peers, things that happen at school, so relationships with teachers, how much the child enjoys school, right up to community level as well. So things like neighbourhood safety and cohesion. So we're really lucky in the ALSPAC data set that we have some measures of all of these things here in this list. These are the ones we've been able to look at in ALSPAC, and we have those repeated over time in most cases. Okay. So moving on to the results, I'm going to take a really broad brush approach to the results, and maybe it's not enough detail, but firstly, the one thing that I wanted to point out was just how prevalent experiences of IPV are in this cohort. So it's about 18.4% of young people had parents that have reported IPV between the top 2 and 9. And 7.6% of them had parents that were reporting that at least 2 time points. So it's incredibly common. It's almost 1 in 5 of our data set. And ALSPAC is quite a selected cohort. So this is really, it's likely to be an underestimate. What's truly going on in the population. In terms of the mean depression score, the mean is 6.6, which seems sort of quite low overall because the range is from 0 to 26, but actually a score of 6 is actually quite high. So the way that the SMFQ is scored, you get for each symptom that you're reporting on, you either say it doesn't apply at all, you're scored 0, it somewhat applies, you're scored 1, or 2, it very much applies. So a score of 6 is sort of equivalent of having 3 symptoms which really potentially are really affecting your life, or as equivalent of a range of symptoms to a lesser degree. So and a score of 12 or more is indicative of a depression of diagnosis, a diagnosis of depression. In terms of the mean positive experiences, I was surprised at how low this was. So this is just a count of the number of different experiences, and the average is only 3.2 in this cohort. Okay. So if we look at the relationship now between IPV and also positive experiences and adolescent depressive symptoms at age 18, the first row shows the association between IPV and depression. So as you probably expect, unfortunately, the only experience of IPV is associated with more depressive symptoms at age 18, and sort of conversely, more positive experiences are associated with lower levels of depressive symptoms. And then when we look, so the rest of the table shows the individual positive experiences. You can see that pretty much all of them are associated with a reduction in adolescent depressive symptoms. So the big question, can positive experiences mitigate associations between IPV and adolescent depressive symptoms? So when we look amongst those with IPV, so the total, as you expect, the total kind of positive experiences is important, but when we kind of unpick that, it's relationships with peers, it's school enjoyment, and it's neighbourhood safety and cohesion that seem to be associated with lower levels of adolescent depressive symptoms. So to conclude, so we did find some evidence of associations between parental IPV and positive childhood experiences with adolescent depressive symptoms. And it does seem to be positive relationships with peers, school enjoyment, and neighbourhood safety and cohesion that were important for reducing depressive symptoms amongst young adults exposed to IPV. And so potentially including positive experiences that are part of a broader intervention might have a bigger impact on public mental health, in addition to just focusing on preventing parental IPV alone, which is obviously something we also want to be doing. And this is really important for sort of shifting that narrative from being sort of so adversity centered and more about building resources and positive and supportive environments for young people. And potentially also providing children and adolescents with positive experiences outside of their homes. So things in school, extracurricular activities, things like the local authority run school holiday clubs that used to happen in most areas. Those are the sorts of things that might well be effective and supportive for young people. So that's me. Thank you.